and pediatric neoplasms. And we will talk mainly about the malignant tumors of pediatrics. Okay. Some facts about the pediatric neoplasm. As we said, we will talk about malignant because neoplasm include also non-malignant tumors such as teratomas or hemangiomas or AV malformation sometimes. It's relatively, or comparing to the adult neoplasm, the pediatric neoplasm are uncommon. And it represents less than 1% of all diagnosed cancers in US, for example. 99% is adult neoplasms. And it differs also from the adult in the prognosis. The pediatric neoplasm, special leukemia, carries much better prognosis, and the distribution by the histology and the tumor sites. Also, pediatric neoplasm may arise from embryological origin, so the site and the histology of tumor differ from that adult tumor. The main topic today is the leukemia, as it is the most common pediatric malignancy, and it okay. Sorry for interruption. That was my daughter. Okay, so the main topic for us today is the pediatric leukemia or the acute leukemia, and it's very important because it's the most common, and recently in the last decade the survival rate reached up to 90%, so it's considered a curable disease. So this is the distribution of childhood cancer. As we said, the most common childhood cancer is leukemia. It represents around 1/3 of all cancers. The central nervous system tumors, about 23%, then the lymphomas, and then there is the rare pediatric or special pediatric tumor like neuroblastoma. It's considered a pediatric tumor. It's rarely seen in adults. Germ cell tumors also most likely it's pediatric cancer. Some bone tumors such as osteosarcoma and Ewing sarcoma in adolescents also treated as pediatric cancer. So starting about the leukemias. Do you know what's leukemia? Okay. Musab, do you have an idea what is leukemia? Amin, Aitan, do you have an idea what is leukemia?
Malignancy
What is
blood.
Yes,
يعني إنه
exactly, it's malignancy of blood cells, precursors. Aya Abu Bakr, do you know what's where leukemia starts? Iman Hamaidat, do you know where leukemia starts?
Bone marrow.
On bone marrow, yeah, because that's where the blood cells are made. So leukemias are a group of malignant diseases. It's not just one type. There are many types of leukemia, and all are malignant diseases. What happens actually, there is a genetic abnormality or genetic mutation at some point of life, which cause the hematopoietic cell to abnormally grow and stops at some stages, which is abnormal. And it's, or we can say it's unregulated clonal proliferation or growth of the blood cells or the blood cell precursor. So as you see, this picture, we have already saw it in the anemia lecture. This is the bone marrow cells. This is how the blood cells are made. So there's the precursors of the blood cells, the precursor of the lymphocytes, precursor of what we call myeloid progenitor that give rise to RBCs and platelets, and the some white blood cell, neutrophil or monocytes, xenophil and basophil. So when there's unregulated proliferation or growth of these precursors and stop at early stage, there will be accumulation of the abnormal precursor, and this will take over the normal cells, and this is the leukemia. As we said, it's like the most common malignancy in pediatric. Many types. The most common type is the acute lymphoblastic leukemia, which happens in the lymphoid progenitor. So it's either B cell lymphoma leukemia or T cell leukemia, and the B cell leukemia represent around 80% of the acute ALL or acute lymphoblastic leukemia. When the abnormal proliferation or unregulated proliferation occurs in the myeloid progenitor, we call it AML, acute myelogenous progenitor, and there's many types of these because many cells are arising from the myeloid progenitor and represent around 11% of the acute leukemias. There is the chronic myelogenous leukemia, which is also malignant, but because it has insidious start and the presentation, or it has like a chronic phase, which lasts for 3 or 4 years. So that's called a chronic myelogenous leukemia, and also it's malignant tumor. Another type, juvenile monocytic leukemia, and this is rare, and there is some also other very rare types. It's rarely seen. Okay, acute lymphoblastic leukemia. This leukemia arises from the lymphoid progenitor. It's relatively common among the pediatric cancer. The incidence is 3 to 4 per 100,000, and the peak age group usually they are toddlers, between 2 to 3 years. Of course, it comes with the older children, it comes with infant, but most children or most initial presentation between 2 to 3 years. Males in almost in all types of leukemia are affected more than females. Now, the etiology why the leukemia happens, it's unknown. The precise etiology is unknown, but there is multifactorial, as we said. As for most the cancers, they are multifactorial, and there are several factors that may increase the risk for developing leukemias, such as genetic factors. Some genetic or chromosomal abnormality carry a higher risk of leukemia, such as Down syndrome, the Fanconi, as we said, Bloom syndrome, telangiectasia. Those having chromosomal instability. Any syndrome with chromosomal instability, those patients prone to have malignancy or abnormal growth. Some environmental factors such as radiation, this is well known and were related well to the later on. Any patient who receive radiation is at higher risk to develop all types of cancer later on. Some drug or cytotoxic drug carries a risk of developing leukemia or other cancers. The chemicals such as benzene also increase the risk of having malignancy. The classification of the lymphoid acute lymphoblastic leukemia is, as we said, the lymphoid, they divided into T cell and B cell. So pre-B cell, the progenitor B, acute lymphoid leukemia, which is the most common. 85% of acute ALL, lymphoblastic leukemia, are of B cell origin. The T cell ALL, which have higher risk, but it's less common, it's 15%. And the other type, we put it alone, although it's from the precursor B cell, it's called the mature, when the proliferation stop occurs later, and we have mature B cell. We call it mature B or Burkitt ALL, which mimic the Burkitt lymphoma. And we put it alone because the treatment protocol for Burkitt B ALL is differs completely from pre-B ALL. So it's treated as lymphoma. And also, when you divide those pre-B or T cell, there are many subtypes of the pre-B and the T cell, and we depend on the certain chromosomal abnormalities, certain translocations, and certain mutations that are seen frequently in these leukemias. So we classify the pre-B, for example, according to the translocation that present. And also these translocation, not only for diagnostic or subclassification of the pre-B or TC ALL, also it carries some prognostic factors. Some translocation carries favorable prognosis, and some will put the patient in the high risk group. So this is some chromosomal abnormality. As you see, this most likely it's in B cell, we use it. For example, translocation 1221 carries favorable prognosis. Some trisomy, when you see a trisomy in the malignant cell, of course we do the chromosomal analysis. When you see trisomies of some chromosomes like 4 and 10 and 17, this carries a favorable diagnosis, and we see it in like quarter of the patient have these translocations. The translocation 922, which known as Philadelphia chromosome, it carries unfavorable prognosis, and it's very important in ALL. Whenever it's found, the patient is immediately high risk patient. But in ALL, it's like 3%. But for example, in CML, it's 95%. In 95%, they have Philadelphia chromosome positive. And the number of chromosome, it's very important, of course. The hyperiploidy, when the malignant cells have like more than 50 chromosome, this is called hyperdiploidy. And this is favorable prognosis when the chromosomal count less than 50, and this is unfavorable. This puts the patient in high risk. Okay. What other good prognostic factor we can find? Because whenever you diagnose an ALL patient, you have to classify him either low risk or average risk, low or average, the same, intermediate risk, and high risk, because every risk group has different protocol, treatment, chemotherapy protocol, and different treatment and different outcome. So the age, whenever the age is between 1 and 10, this carries a good prognosis. And this is from the initial diagnosis, from the history. So at the presentation, any patient age between 1 and 10 years, this is good. Any patient comes as infant, this carries a bad prognosis. And the old one with the leukemia more older than 10, it's more like adults, so it carries like bad prognosis. When the white cell count is low, this is better. When it's below 50,000, it's better. Whenever there is a high white count, when there's 100,000 or 200,000, this is very poor prognostic factor. Some chromosomal abnormality, also some translocation or mutations. As we said, TEL AML, one gene, This is very favorable prognosis whenever found in the in the malignant cell. This is very good prognosis factor. The Philadelphia chromosome, when it's negative, this is good. The hyperploidy, as we said, and there is a rearrangement we call MLL. When it's present, it's very poor prognostic factor, but the absence of this MLL rearrangement is very good for the patient. The immune phenotype, the precursor B cell, the B cell ALL carries much better prognosis than T ALL. Also, the ALL have the ability to go to the CNS system. So when there is no CNS involvement, this is good. And the most important factor that we use to know the prognosis of the patient is the early response to chemotherapy. We assist the patient at day 14 and at day 28 after starting treatment. If there is a good response, this is very good prognostic factor, and this is the most reliable one. So how does the leukemia patient present? First of all, as we said, the abnormal cells in the bone marrow take over the normal cells. So there is a picture of bone marrow failure. And the patient, so severe anemia, severe leukopenia, severe thrombocytopenia, and this manifests as anorexia because of the anemia, fatigue, malaise, and irritability. Because they have low leukopenia, so they are immune deficient. They always have fever from the disease itself and from other infection. Because of the bone marrow are involved and it's full of abnormal cells, they sometimes, or most likely, they come with the bone pain. The patient will give you history of bone pain, and most likely they will come with history of X-ray because the differential diagnosis is fracture, because it's very severe pain and it's poorly diagnosed and unexplained. And mainly it's in the lower extremity. And there is like half of the patient, they give a history of upper respiratory tract preceding the diagnosis by 1 or 2 months. And then, as we said, there is the bone marrow failure, there is severe anemia, severe pallor, petechia because of low platelet, bleeding, epistaxis. It's very common. Severe overwhelming infection because of the leukopenia and neutropenia. This is all are symptoms of bone marrow failure, because bone marrow is empty of normal cells. Sometimes they come with organ infiltration. The malignant cells infiltrate other organs, such as lymph nodes. They come with lymphadenopathy. They also infiltrate commonly the liver and the spleen. They come with hepatosplenomegaly. In male, we have to pay attention that for testicular involvement, any patient with diagnosed recently or at initial diagnosis of leukemia, you have to test the testicle. If there is hypertrophy, you have to rule out the involvement of the testicle. Also, as we said, it can invade the central nervous system. Sometimes the patient comes with renal failure because the malignant cells also infiltrate the kidneys. So those all we have to pay attention and should be tested at the diagnosis. So respiratory distress may come particularly in T-cell leukemias, because they present with the thymus mass and large mediastinal mass that compressing the airways, and also maybe from severe anemia. Severe anemia, I mean, they may come with hemoglobin of 3, thrombocytopenia like platelet of 1. Leukopenia may come with 1,000. So it's very severe bone marrow failure. What we can find in the physical examination, first of all, pallor and listlessness. Listlessness is like lack of energy, apathy, poor concentration, dizziness. So the patient is abnormal. The thrombocytopenia, also we see the symptoms of thrombocytopenia like petechiae, berbera, ecchymosis, bleeding from mucous membrane. If there is infiltration of the organs, lymphadenopathy, splenomegaly, the most common splenomegaly and hepatomegaly. And also when the patient comes with bone pain, you can find like a pinpoint tenderness, severe tenderness. It's mimically osteomyelitis. When there is a CNS involvement, it's either manifest as increased intracranial pressure, and this you can find by the ophthalmoscope. You can find the papilledema, the edema of the optic disc, and may manifest as like retinal hemorrhage also. There may be a dural infiltration that compress some areas in the brain and manifest as neurological symptoms. And as we said, testicular examination is crucial in any male leukemia. If there is a testicular mass or hypertrophy, should be examined by ultrasound and by biopsy to rule out the infiltration. Respiratory distress, any patient with leukemia, whether B or T cell, you have to do an X-ray to rule out the mediastinal mass, especially in T cell later on. So how do we diagnose leukemia? First of all, when the patient comes with this severe symptoms, with the severe anemia and severe thrombocytopenia, the bone marrow failure symptom, we do immediately a blood film. When there is a very high count of blast cell, this malignant cell we call blast cell in the bone marrow, it goes into the circulation. So basically, you see the blast cell in the blood film, the peripheral film, and this abnormal lymphocyte, you see it in the picture. These are the blast cell. As you see, it has very large nucleus. It has very scanty cytoplasm. Those are abnormal white pieces. Those are the blast cell. And most of patients, they have blast cell in peripheral blood. And you can diagnose the type of the leukemia by doing like flow cytometry to the peripheral blood. The bone marrow aspiration is must in all patients with leukemia. It's the gold standard to diagnose, and you have to send this bone marrow for flow cytometry. You have to isolate this blast cell and cytogenetic to know the type of the leukemia, whether B or T cell, and the molecular study for the chromosomal number, for the translocation known, for abnormal mutations or rearrangement that present. And also at diagnosis, LP and CSF examination. You have to examine CSF, cerebrospinal fluid, for presence of blast or not. Chest X-ray, as we said, to rule out mediastinal mass, and LDH usually, or in most cases of leukemia, it's very high, and it makes you think that it's leukemia when the picture is not fully shown. The differential diagnosis, as you said, the patient may present with severe bone marrow failure, so any aplastic anemia could be put in the differential. The failure of a single cell line when the patient presents earlier, there won't be a full picture of bone marrow failure. It's more like anemia alone or thrombocytopenia alone. So single cell line failure, such as TIC, transient erythrocytopenia of the childhood, or ITB or other acquired neutropenia or congenital types, it's also in the differential. Some infection that comes with lymphadenopathy and hepatosplenomegaly, for example, EBV virus infection, also could be a differential. Other types of leukemia, such as AML or other malignant tumors that infiltrate the bone marrow, such as such as lymphoma or neuroblastoma that invade the bone marrow and cause bone marrow failure. So how do we treat leukemia? As I said, the leukemia is curable disease. And the treatment is because without treatment, the disease is fatal. So the most important prognostic factor, as I said, the response to treatment. When there is an early response to treatment, this is a very favorable prognosis. Sorry again for the interruption. You are lucky today to hear my children's voice. Okay. So without effective therapy, as I said, the disease is fatal. And with therapy, there is a survival rate, a 5-year survival rate of over than 80%, which is very important. The duration of treatment is according to the risk factor group. The low risk group, they usually being treated for like 2 years. The higher risk group, they usually treated for longer period and with stronger chemotherapy, and the treatment lasts for 3 years. So the most important thing that we divide the patient to low risk, intermediate, and high risk according to the prognostic factor, and then start the chemotherapy protocol. In all the groups, there are several phases of the treatment. The first phase is remission induction, which is to cure the bone marrow immediately, and this is for 1 month. You give very aggressive chemotherapy to clear all bone marrow, the normal and the abnormal cell, and then the consolidation and intensification to keep this remission for like a period of 2 months. And this, there is like entire maintenance phase, and then you go to the long phase, which is the maintenance phase, and this is usually 1.5 year or 2 years. And this maintenance phase, it's just only oral drugs, and you allow the bone marrow to grow slowly and under control, because you give chemotherapy, you suppress to some point, and the patient will have almost a normal life during this phase. So the aggressive chemotherapy is usually 6 months, and then the patient will have oral therapy at home and will live his life normally. So several therapeutic agents used in ALL, like for example, first week, it's only steroid, just steroid, plus because we do the LB, and at the initial presentation, we give chemotherapy intrathecally, IT, that means intrathecally in the CSF directly. We give 1 dose of methotrexate, and you give just 1 week of a high dose steroid. And then you continue with other chemotherapy, such as vincristine, danomycin. The maintenance therapy, they only receive mercaptopurine, the 6-MP, and this is oral daily drug. And they also receive once weekly oral methotrexate, and this is like for 1.5 years. And they just have to do a blood test or a complete blood count every 1 to 2 weeks. Okay, this is all about the acute leukemia. The AML, acute myelogenous leukemia of myeloid origin, and this is the blast in myelogenous leukemia. As you see, it's also large nucleus with several nucleolus, and the cytoplasm is much more than in the blast in ALL. There are many types of myelogenous leukemia, and the French, American, British classification are still used. In ALL, we use the WHO classification, the World Health Organization, but in acute myelogenous leukemia, most countries use the FAB classification, the French, American, British. And there's 8 types of the myelogenous leukemia. according to the differentiation and the types of cell or the type of the affected line, such as erythroid if the RBCs are affected, or megakaryocyte if the platelet precursor are affected, if the neutrophil are affected, and how differentiated. This is how we classify the acute myelogenous leukemia. Uh, the signs and symptoms are the same as in ALL. It's bone marrow infiltration, bone marrow failure, bone pain, severe infection, severe anemia, severe thrombocytopenia, and its symptoms. Usually, AML has higher white BC count at presentation than that ALL. You see a white BC count around 100,000. Some special presentations, some special types, such as M3, they may present with picture of disseminated intravascular coagulation, severe overwhelming infection with the IC. Other types, such as M4 and M5, may present with gingival infiltration, and the patient comes with severe gingival enlargement that dysmorph his face. In Down syndrome, AML, and the Down syndrome carries higher risk to, especially before age of 3 years, to have AML than ALL. The M7 type, the platelet type, is the most specific for Down syndrome. Most patients, as I said, in Down syndrome before age of 3 years, they have higher AML incidence. After the age of 3 years, they are as the same as the other population. ALL is much common. In general, AML has poorer prognosis than ALL. ALL is much better, and most patients of AML, they need like aggressive chemotherapy, and after that you need to do a bone marrow transplantation to cure them. For most cases, some cases will respond with favorable prognosis will respond to aggressive chemotherapy alone, but in most cases, no, you have to do aggressive chemotherapy, and because there is high relapse rate, you have to do a bone marrow transplant immediately. Okay, now the CML, the chronic monocytogenic lymphoblasm leukemia. As you see, this is the bone marrow picture of the CML. This is the blast of the CML, the very large nucleus. Again, there is several cytoplasmic inclusion, which differ from the ALL and AML blasts. Why do we call it chronic? Because the initial phase, there are two phases. The initial or the stable phase, it's the chronic phase, where there's just one malignant clone that produce high white BCs. The patient only have high white BCs. The anemia is very mild. The thrombocytopenia, it's rarely present, and usually it's thrombocytosis. So the patient will continue to have like high white blood cell count, mild anemia, thrombocytosis for like 3 or 4 years. And the next phase, which is the chronic phase, is the blast crisis, where the picture is completely goes to acute ALL, and the patient will present exactly like any ALL patient with the complete bone marrow failure and the other symptoms that we have mentioned earlier. Splenomegaly is very marked and is usually present in all patients in the chronic phase even. And as I said, the Philadelphia chromosome, the translocation between chromosome 9 and 22, which has poor prognosis, is present in 95% of CML cells. And so why this is important? Because this translocation results in abnormal protein or fusion protein we call BCR-ABL. And this abnormal protein is responsible for the abnormal proliferation of those cells. The treatment earlier, the hydroxyurea and the bisulfan was used, but now there is the imatinib or the imatinib era, which is a drug that that is, was invented specially or specifically for the Philadelphia chromosome protein, the BCR protein, and it targets this protein and stops its production. And there is a very good responses rate on imatinib. So all CML patients are on imatinib, and the cure rate are very is very is very good comparing to the earlier treatment. Bone marrow transplant, in some cases, especially those who come with the plastic crisis, the ALL, because they are high risk ALL, they will be high risk because of the Philadelphia chromosome. So this is all about leukemia. Do you have any question?
يعطيك العافية دكتور.
نكمل ولا في سؤال؟
بس في سؤال إذا ممكن.
تفضل.
بس ككرونيك لوكيميا، كيف بدي إنه أشخص الشخص إنه قبل فترة، يعني قبل ما يتحول زي الأعراض الأكيوت أو الكرايسيس؟
كيف بنشخصه باي بون مارو، بنشوف البلاست موجودة أول
بس
شيء.
يعني إنه إيش الأعراض اللي راح تطلع عليه؟
بيجي infections because بيكون عنده high white vessel count, and حكينا اللوكيمياز أغلبهم عندهم high white VC, but those white VCs are abnormal, they are not functioning well. So لما يجي عندك severe infection تعمل له white count, the simple thing, the CBC. You will discover abnormally high white VCs. When you do the blood film, you may see the blast in the peripheral blood, and then you go immediately for bone marrow and diagnose them. So the first presentation is infection or the symptoms of single line failure, the white VCs. And immediately when you examine the CBC and the blood film, you will find the blast and you will do bone marrow. Okay, and حتى لو عندهم high white VC count, those are abnormal cells, are not functioning. So they are immune deficient, they come with severe infection.
تمام، شكرا دكتور.
نعم. اوكي، هلا راح نحكي عن الليمفوما. So lymphoma هي tumor of the lymphoid tissue, mainly the lymph nodes, the spleen and the liver. We see it usually in adolescent, and it's most common cancer in adolescents, even commoner than the ALL. And there are, we divide it in two major types, the Hodgkin disease, and we call it disease, and the non-Hodgkin lymphoma. The Hodgkin disease, it carries much better prognosis than non-Hodgkin. The chemotherapy for Hodgkin disease is like low doses and a short protocol. Non-Hodgkin is it's aggressive malignancy and needs aggressive chemotherapy. The prognosis for Hodgkin disease is very favorable, and the cure rate may reach 100%. It's like the curable disease. Non-Hodgkin lymphoma, but in good cases, it may reach like 70%. The etiology, it's always unknown, the etiology, the exact etiology, but there are several factors that may increase the risk for developing the lymphoma. EBV infection, Epstein-Barr virus infection, plays a causal or major role in both conditions. So it's really a risk factor to develop lymphoma. So usually the lymphoma, we don't see it in before age of 10. It's mainly adolescent tumor and adult tumor. The non-Hodgkin lymphoma can be seen in with the younger ages, and the incidence increase as the age increase. So it doesn't have like exact peak. So as we said, the non-Hodgkin disease or non-Hodgkin lymphoma is very aggressive malignant tumor. There are many types, or 3 histological types for it. And many immune deficiency syndromes, such as HIV, they are prone to develop non-Hodgkin lymphoma. So this is not very clear, but That's important. The types of or the histological category of non-Hodgkin lymphoma. The small non-cleaved, we call it the Burkitt lymphoma. If you remember, we call the mature B-cell ALL also Burkitt because it's malignant, highly malignant, and it's treated just like the Burkitt lymphoma. And also in the Burkitt lymphoma, as you see, it's on the surface or the CD marker, the cell differentiation marker, it's similar as mature B cell. Usually it comes in the abdomen, in the spleen, in the liver, and may come in the lymph nodes of the head and neck. The most common translocation, it involved chromosome number 8. It's very important, the translocation on chromosome number 8. Usually it's related to non-Burkitt lymphoma. The other type is the lymphoplastic and the large cells, and those are mainly in T cell origin. And they come in neck, and they come with anterior mediastinal mass. The large cell, mainly it's T cell, may come with B cell, but usually the primary site differs in the lymph nodes, the skin. It may also involve some soft tissue and even the bone. The clinical manifestation, how does the patient present? Usually they come with lymphadenopathy, and usually it's cervical or supraclavicular lymphadenopathy. The supraclavicular lymphadenopathy, it's always pathological. So any patient come with supraclavicular, you have to do biopsy right away. But the cervical lymphadenopathy is very common in an infection, and so this is the cause of delay of the diagnosis, because many patients comes with the cervical lymphadenopathy. You don't do the biopsy right away. You defer the patient for later, suspecting just reactive lymphadenopathy. It's painless, it's firm. Usually they need time to grow, and then you suspect the lymphoma or the malignancy. Other site is the mediastinal lymphadenopathy, as we said, especially in T cell origin, and they present with severe shortness of breath and severe respiratory distress, and may come with lung collapse if there is good pressure on the brachial and right or left brachia, and also they may come with pleural effusion. Other thing is the B symptoms. This is very important as diagnostic and prognostic factor, and even we use it in classification of this disease stage in the staging system. The B symptoms are three important things. First of all, fever, unexplained fever, more than 38 for like 3 days. Drenching night sweat, and this is when the patient, even in the cold weather, come with the or awake at morning with the sweat. He's drowning in sweat. The whole bed is like wet and moist with the sweat. It's abnormal sweating. And the third thing is unintentional weight loss. They come with a history of like 10% of their weight loss within 6 months. The Burkitt lymphoma, as I said, it may present in the abdomen, in the spleen, or the lymph nodes of the abdomen, and they may come with just abdominal mass discovered by the parent. And some African type, they come with jaw masses. So the diagnosis, the gold standard diagnosis made by the tissue biopsy. You have to do biopsy from the mass or from the lymph nodes, and you have to do the histology and cytology for this biopsy. For example, in Hodgkin disease, in pathohistology, you see the Reed-Sternberg cell, the all eye, which is one large cell with two nucleus. It's very pathognomic for the Hodgkin lymphoma. You have always to do chest X-ray and diagnosis to diagnose the mediastinal mass. And this is very important in ALL or lymphoma, because when any patient, you have to sedate for bone marrow, and any intubation with a mediastinal mass, it's very risky. So In some patient, those who doesn't have mediastinal mass, we usually give like light sedation for bone marrow examination. But in those who have the mediastinal mass, you have to intubate immediately for bone marrow. You don't give sedation with this respiratory distress or mass compressing their airways. So it's very important. You don't do the bone marrow, you don't do the further examination or the LB before the you know if there is a mediastinal mass or not, because you have to intubate or you have to give like light sedation. CT scan is very important for staging this, because we need to know the size, if the disease is bulky or not. Bulky, we mean like certain volume higher than its bulky disease. There's a large disease mass. Or unbulky, the sites of the disease above the diaphragm, below the diaphragm, at the both sides. And always you have to do a bone marrow aspiration, because lymphoma, it's one of the malignancy that can invade the bone marrow. And you have to know if it involves the bone marrow. And if it involves the bone marrow, you have to change the protocol and treat them as leukemia. Of course, for initial diagnosis, the CBC and blood chemistry, and we mean by chemistry, liver function test, kidney function test, the electrolyte, phosphate, and calcium, for example, chloride. You have to do all that at diagnosis. So, for example, for Hodgkin disease, we use the Ann Arbor staging system, and it's 4 stages. It's according to the site, for example. In stage 1, it's having the lower risk. You have just one site involvement or single group of lymph node involvement. In stage 2, you have more than 2 groups involved, but in the same area. It's above or below the diaphragm. We use the diaphragm. So above the diaphragm in two sites, or below the diaphragm in 2 sites, it's stage 2. Stage 3, when you have above and below the diaphragm mainly, and stage 4, when you have disseminated disease above and below the diaphragm, invading invading the other organs, such as liver, spleen. The Reed-Sternberg cells, as I said, this is the all eyes, the large cell with 2 nucleus and 2 nucleoli, similar to the عيون البومة زي ما بيحكوا. Okay, the mediastinal mass, as you see, this is a mediastinal enlargement. You have to do a CT, and this is the mass on the CT, this is the mass on X-ray. It's very important to diagnose it before starting your other diagnostic procedure. Differential diagnosis of the lymphoma. As we said, it may present with lymphadenopathy. So any infection that causes lymphadenopathy is in our differential diagnosis list, such as mycobacterial infection, toxoplasmosis, EBV. When the patient comes just with a single neck mass, other abnormality or congenital, such as branchial cleft or thyroglossal duct cyst, also is in our differential. When you have bone marrow failure or bone marrow mets, leukemia is top of your differential diagnosis. When the Hodgkin lymphoma, especially the non-Hodgkin lymphoma, especially the third type, comes in the soft tissue, the rhabdomyosarcoma, the nasopharyngeal carcinoma, germ cell tumor, also are in our differential list. Mycobacterial infection for the lymphadenopathy, and in some Burkitt lymphoma, the abdominal masses, they may come with the acute abdomen that might make appendicitis. So the differential diagnosis depends on the initial presentation. So the treatment of lymphoma. For Hodgkin disease, as I said, it's a curable disease. It doesn't need aggressive chemotherapy. It needs combination of several agents at low doses, and usually it's 4 to 6 doses, and that's it. It's like 4 months or 6 months, and they will be done, and they will be cured. Some patients may need a low dose radiotherapy, but recently, because the better prognosis and the good combination of chemotherapy, most patient doesn't receive radiotherapy. Some agents are cyclophosphamide, vincristine, procarbazine, doxorubicin, uh, but those are all given in low doses, not like in non-Hodgkin lymphoma or in ALL, for example, cyclophosphamide. For osteosarcoma, you give 5,000 per kg. In Hodgkin, you give like 400 or 500. So comparing to other malignancy, really it's low doses. And why it's important, because the side effect of those chemotherapy in low doses is very minimum. The more aggressive chemotherapy, as I said, is for non-Hodgkin lymphoma, and you give this almost the same agents but with much higher doses. So the patient may die from the side effect of those high doses, or may suffer from severe complication that affects his life later on. But in general, the Hodgkin or the lymphoma are good diseases. The prognosis is generally excellent. If someone asks you to choose one malignancy for example, the better one, you choose the Hodgkin disease. The chemotherapy is short, the agents in low doses, and the cure rate is very high. So there's approximately, as we said, 90% overall for lymphomas. In non-Hodgkin, it's like 70. In Hodgkin, it's like 100. And this is about lymphoma. Do you have any questions? Okay. كمل. هلا بدنا نحكي عن الله يعافيك. Okay. هلا بدنا نحكي عن central nervous system tumor, which are the second most common tumors in pediatric. رح نحكي عن brief إن شاء الله. Okay. So as I said, it's the second most common malignancy in pediatric, and it's the most common solid tumor. The lymphoma and the leukemia are called hematological tumors, and the central nervous system and the other, for example, bone tumors are solid tumor, and the most common solid tumor is the CNS tumors. Most of CNS tumor, unlike adult, it's primary tumors. It arises from CNS itself. It's not myths from other tumors, such as adults. For example, adult, the prostatic or the lung tumors or breast tumor may metastasize to the CNS system. But in pediatric, most likely it's primary tumor. It arises from the CNS cells itself. For example, there is the astrocytomas, the embryonic neoplasm, such as medulloblastoma, ependymoma, or germ cell tumor. They all arise from the CNS cells. They are not myths. The incidence is considered rare, 33 cases per 1 million in the United States, for example, and it peaks before the age of 10 years. So those primary tumors seen before the age of 10 years. After that, it's most likely the same as adults. The etiology is the same as most tumor malignancy. It's unknown why they have this tumor. There is some factors such as the syndromes or the chromosomal instability, the neurofibromatosis, especially type 1 and type 2, the Leigh-Freumann syndrome. Those are also, this syndrome also have chromosomal instability, the von Hippel-Lindau syndrome. The radiation also increases risk of having CNS tumors. Some chemotherapeutic agent increase the risk of the CNS tumor. But again, the exact cause why or the direct cause is unknown. The clinical manifestation, it depends. There is a clinical manifestation or presentation of the increased intracranial pressure when the tumor occupy some space in the skull, so the pressure increase, and this manifests by lethargy, headache, and vomiting. In older children, in infant, when the suture is still open, they manifest with increased head circumference. Also, an increased intracranial pressure when it's chronic, when the diagnosis is late. There will be a sixth cranial nerve palsy. This is from the increased ICP, intracranial pressure. They come with sixth cranial palsy. They come with like deviation of the eye. And they go first to the eye doctor, to the ophthalmologist, where you can discover the sixth nerve palsy, and then they usually refer them to us to diagnose them or to do MRI. In infants, it comes with irritability, anorexia. In toddlers or older, poor school performance. Some infants come with loss of development milestones. They walk and they suddenly stop walking, or they are limping, or they have aphasia, they stop talking, or affecting the hearing. So it's according where the tumor is. Cranial nerve deficit, usually with the posterior fossa tumor in the brainstem. It may come with all type of cranial nerve deficit. Some tumors in the supratentorial tumors, the patient may come with seizure. It may be the first and the only presentation. They may come with some weakness, hemiplegia, paraplegia, or numbness or sensory changes. If the tumor is in the pituitary or near the pituitary gland, it may present with neuroendocrine effects, such that either increase or decrease in the pituitary hormone production, such as galactorrhea, prolactinoma, precocious puberty, or excessive or poor growth. According, is it increase in the hormones or decrease? The cerebellar tumors, the posterior fossa tumors, associated with instability or ataxia, and this is very common presentation. The laboratory studies that is used to diagnose and stage the tumors, the main or the hallmark of the brain tumor is the MRI. The magnetic resonance imaging is used in all brain tumor and in all brain tumor diagnosis and follow-up. And in most cases, we do the brain and the whole spine MRI. You don't do the brain alone, because to rule out the spinal myths or spinal masses, or even we call the spinal drops. You may see some malignant cell at the end of the spine that drop in the CSF. The CSF examination, the cerebrospinal fluid, also has to be examined for presence of the metastatic. You may not see the tumor on the MRI of the spine, but when you do the CSF examination, the lumbar puncture and CSF examination, you find those metastatic cells in the CSF. Now you have to pay attention because of the increased intracranial pressure. So in all patients, you want to do LP, whether to rule out meningitis or to diagnose like malignancy or part of workup for leukemia. You have to pay attention if there is a signs of ICP, increased intracranial pressure, like papilledema or the lethargy and the symptoms we mentioned before. You have to do, like, if you don't have MRI right away, you have to do CT scan and see if there is increased intracranial pressure. Because if there is increased intracranial pressure, the LB is contraindicated even in meningitis patients because of the risk of brain herniation. And we mean by brain herniation, when you do the LB on the patient will die on the table immediately because of brain herniation. The brain stem will drop in the spinal canal and will be pressed. And as you know, the brain stem contains all vital centers like respiration and the cardiac rhythm and cardiac rate. The differential diagnosis uh, of any CNS mass, it's, on the pediatric, it's malignant until proved otherwise. There are some benign tumors. AD malformation also may present as with the same symptoms or aneurysm, the same symptoms as CNS tumor. Any mass or any space occupying lesion will come with the same picture of CNS malignancy, brain abscess, hemorrhage, pseudotumor cerebri, which is benign increase of the intracranial pressure, and in this case, the only case that you are allowed to do LB because the pressure is equal in the spine and in the brain. Vasculitis, because the inflammation and edema increase intracranial pressure, and also it's present with the same picture as vomiting and headache. Any metastatic tumor also is in the differential, although it's very rare in pediatric. So the treatment of the CNS malignancy, it depends. It could be chemotherapy, radiotherapy, and surgery. Those are the three main options of treatment, and usually we use it all in CNS tumors. But it depends on the location, the size, and the symptoms. For example, the patient who presents with severe intracranial pressure symptoms, you give right away high-dose dexamethasone to reduce the edema that's surrounding the tumor, to reduce the symptoms of the increased intracranial pressure. Radiation therapy is usually used, especially in glioma. Surgical excision, either the better is the complete surgical excision, but if it's unfeasible or impossible, you have to do maximum or maximal debulking. You have to remove as much as you can, because some tumors are in vital sites. You cannot remove it all, so you remove as much as you can. This, we call it maximal debulking, and of course it carries poorer prognosis than complete excision. In general, childhood malignancies are very bad illnesses, and the prognostic with treatment and with aggressive treatment, with surgery and high doses chemotherapy, either intrathecal or directed in the brain, or the high doses IV, and plus radiotherapy, the survival rate, 5-year survival rate, is 50 to 60%. And even those who survive those tumors, they will be left with severe neurological deficits. So it's very bad to diagnose a child with CNS tumor. The type of, or the most common CNS malignancy, we divide into infratentorial, the posterior fossa in the cerebellum or brainstem, and the supratentorial in the hemisphere, cerebral hemisphere, both hemispheres. The infratentorium, the astrocytoma in the cerebellum, and the medulloblastoma, it's very aggressive tumor in the brainstem. The glioma is the worst tumor at all, infra or supratentorial. For example, in medulloblastoma, we cannot see it supratentorial, but the astro or glioma you can see anywhere. As you see, the supratentorial, or in the brain cerebellar hemisphere, you can see also astrocytoma, glioblastoma, and these are very bad disease. As you see, the 5-year survival rate is 0 to 5% with treatment. So those tumors are not really treated; they are at palliative therapy right away. Ependymoma have a good 5-year survival rate, for example, but it's recurrent. Craniopharyngioma has better survival, or almost the better survival rate with the optic glioma, but the craniopharyngioma, usually it has, or it leaves the patient with severe neurological deficits. For example, this is MRI for on the left side for medulloblastoma, as you in the brainstem in the posterior fossa, and usually it grows for in like very large size. And this is the supratentorial astrocytoma. As you see, the MRI is very helpful in differentiating those tumors, although the definitive diagnosis by biopsy. اوكي، حد عندهم سؤال عن ال central nervous system tumor؟ اوكي، هنكمل neuroblastoma. This is another special type of pediatric tumor. It's rarely or it's not seen in the adults. It's a solid tumor. It's the most common extracranial solid tumor. And most common malignancy in infancy in the first year of life. Most cases are infants most cases of neuroblastoma are infants. And this tumor is derived from a neural crest cell, either in the adrenal medulla or the paravertebral ganglia. So they may come with the adrenal enlargement or adrenal mass, or they come with the sympathetic nervous system or the ganglion paravertebral ganglion masses. The etiology is always unknown, and the median age as it's like 20 months. It's before 2 years. The clinical manifestation, it depends on the where the tumor arises from. In the adrenal gland, for example, the patient may present with abdominal mass. For example, in the tumor, in the paravertebral tumor, it may invade the spinal canal and present with the cord compression. For example, 45% of the tumors are from the adrenal gland, and those come with abdominal mass. 25% arise from the retroperitoneal sympathetic ganglia, and those also come with abdominal mass. Okay. The metastatic disease, usually a diagnosis, this disease have myths at the time of diagnosis, because it doesn't show up until the mass is very large and the disease is metastasized already. In the metastatic disease, the patient appears very ill, and it have like systemic or general complaints such as fever, weight loss, and pain, abdominal pain, or pain according to the site of invasion. As I said, the paravertebral ganglion involvement, it may involve also the spinal cord, and may come with the lower limb weakness, the constipation, severe constipation, urine retention, the Horner syndrome also when there is a cervical ganglion involvement. Also, what's special about this neuroblastoma is what we call the paraneoplastic syndrome, because they grow from the adrenal gland. They have many hormones like adrenaline, or like sudden higher doses of adrenaline are released in the circulation. They come with secretory diarrhea, flushing, profuse sweating, or also myoclonus, sudden movement of the extremities. Other manifestation, it's according to what organs are infiltrated. Hepatomegaly, bone infiltration, bone lesions, bone marrow also can invade bone marrow and they may come with bone marrow failure. Lymph nodes also enlargement, lymphadenopathy. When there is a myth to the orbital bone, they come with periorbital ecchymosis, and this is very common in neuroblastoma patients. What laboratory study and imaging study I need to diagnose and to as an initial workup for neuroblastoma? First of all, the CBC. You have to see the YPCs and the signs of bone marrow involvement. X-ray in the abdominal mass, you can see the calcification within the abdomen, and this may give me or may differentiate the neuroblastoma, for example, from Wilms tumor. Neuroblastoma, usually they have calcification. Wilms tumor, is also a disease of the kidney, but this is adrenal. But usually, because the mass is very large, you cannot differentiate. So, for example, the calcification X-ray, it's more like it's neuroblastoma, not Walden's tumor. The urinary catecholamines, the catecholamines from the adrenal gland or from the tumor cell, that's the one which is responsible about the paraneoplastic symptoms. Like 90% of the patient will have positive manelic acid and homovalenic acid in the urine, and this is very important. This is almost the diagnostic test. When you have this catecholamines increased in the urine, it's neuroblastoma. The definitive diagnosis is tissue biopsy. You have to do the CD or the cell differentiation immune phenotype and to see this is a neuroblastoma or not. But the urine catecholamine is very important and initial diagnosis because the tissue biopsy is not possible at the initial diagnosis in all cases. So you treat and you diagnose according to the catecholamine. And also it's very important in the following up the tumor. Usually we follow the level and it should be declining over the time, at any time this catecholamines increase, you have to reevaluate for disease relapse or progression. CT scan, very important to see the mets and the sites of infiltration and the sites of the other the other ganglion, paravertebral, especially because it's not reachable and it's not won't show itself in X-ray. So you have to do CT scan to see if there is another site of tumor. The MIBG scan is very important and it's specific for neuroblastoma. Bilateral bone marrow aspiration is mandatory in all patients. You have to take a bone marrow biopsy from 2 sites, either from 2 iliac bone, the iliac crest, or from the femurs, or from the tibia, but you have to take from 2 sites. The differential diagnosis, as I said, the top differential diagnosis is Walden's tumor, especially in adrenal neuroblastoma, because Walden's tumor is kidney disease, kidney tumor, and at the presentation it's very large mass. You cannot differentiate it where it's arise from the adrenal or from the kidney, and the same story with the adrenal neuroblastoma. Leukemia also may be in the differential list if there is a bone marrow failure or bone mets to the bone marrow, and it's very common in the neuroblastoma. In some cases, if they present or if they come with symptoms of periorbital mets, they come with raccoon eyes, so child abuse, you have to consider it. The treatment for neuroblastoma, usually we have to classify the patient and to do staging system for the disease. There is low risk that need like 2 or 3 courses of chemotherapy, and that's it. The severely metastasized tumors need surgical resection and even may need radiotherapy, plus of course the aggressive chemotherapy. So it varies from like single or 2 agents chemotherapy to many agents plus surgical resection plus radiotherapy. This is a summary of the neuroblastoma and the presentation and the organs may be involved. At presentation, the MRI imaging of the neuroblastoma. And now we'll talk about Walden's tumor. It's a renal tumor, and in childhood, any renal tumor, it's Walden's tumor until proved otherwise. The mean age, as you see, it's 3 to 3.5 or 4 years, and it's a little bit older than the neuroblastoma. Some congenital anomalies increase risk for tumors. For example, a patient with Pickwick-Wiedemann syndrome, which is hemihypertrophy, they have increased risk to develop Walden's tumor, so they are screened annually for Walden's tumor. Aniridia sporadic or as part of syndrome increase also the Walden's tumor. The most common presentation is abdominal mass. They don't show up until the mass is very large, and usually the parents during giving the path to their kid, they discover this mass and they come for examining. Otherwise, this is the most common presentation. It's silent until the mass is very large to be palpable by the parents. Some lucky patients may may diagnosed earlier with abdominal pain or fever or hypertension when the renal vein or renal artery compressed a little bit, or maybe by hematuria, and those come usually earlier. So the treatment usually it differs from land or from, for example, America or in Europe, but it's chemotherapy plus surgery plus nephrectomy to remove the kidney and tumor itself. The chemotherapy, it could be neoadjuvant plus surgery, or you start with surgery and then give adjuvant chemotherapy. In Europe, for example, you give neoadjuvant to shrink the tumor a little bit to have a clear margin, and then you do the nephrectomy, and then you give the adjuvant chemotherapy. So the mass is really that big in one's tumor, and it's easily palpable by the parents. It doesn't need an expert hand to palpate it or to discover it. It's usually huge tumor. That's why we don't differentiate it immediately from neuroblastoma, because it takes the kidney, the adrenals, and you cannot differentiate even sometimes in imaging. Okay, now we will talk in brief about the sarcomas. It's very common in adolescents. The sarcoma, it's either soft tissue sarcoma, such as rhabdomyosarcoma, or soft tissue Ewing sarcoma, or bone cancers. As a soft tissue sarcoma, the rhabdomyosarcoma are the most common in children. In bone cancers, we have two types of sarcomas: the osteosarcoma, which is the commonest, and the Ewing sarcoma. The osteosarcoma, usually it's located in the epiphysis or metaphysis of the long bone, usually at the end of the femur or the proximal part of the tibia. This is the usual or the exact site where you see the osteosarcoma. The Ewing sarcoma, it's come in the diaphysis of the long bone, and also seen in the flat bone, such as the pelvis, the scapula, the sternum, or the ribs. Also, you can see the Ewing sarcoma. The difference between them, the age of presentation or of incidence is almost the same. They come in adolescent. Male to female, it's higher in male in both type of tumor. In osteosarcoma, for example, some radiation or some risk factor are identified, but Ewing sarcoma, we don't have a risk factor. The X-ray, usually when the patient comes he presents with bone pain, or with the most common presentation is bone mass, swelling of the leg. So most commonly, the first diagnostic test is X-ray. The patient will come to your clinic with an X-ray. On osteogenic sarcoma or osteosarcoma, you see the sunburst picture, which it's sclerotic destruction of the bone, and you see it on X-ray as sunburst. But in Ewing sarcoma, you see the periosseal lytic. It's like parallel to the bone, and it's like you are peeling the bone. It's onion skin. Both tumors metastasize to the lung and to the bone. We have skip lesion, for example, that you have site of a free of tumor, and then you have site of involvement. But we call it skip lesions. The treatment is usually aggressive for both. They need aggressive chemotherapy. They need surgery for both. Limb amputation is very common in osteosarcoma. And Ewing sarcoma is according to the site of the tumor. Overall, the osteosarcoma carries a better prognosis. It's like 70% cure, total cure. And for Ewing sarcoma, it's 60%, and it's according to the site, such as pelvic Ewing sarcoma carries poorer prognosis. and then the limbs or the ribs or Ewing sarcoma. When the at presentation, if the disease is already having mets or metastasized, the cure rate decline from 70 to 20%. So any patient with for example osteosarcoma with lung nodule, the cure rate drops from 70 to 20%. It's fatal when it's the late presentation. It's fatal for them. So this is what I mean by sunburst. In the left side, you see it's like sun shining in the bone. This is a lytic lesion. But in Ewing sarcoma, also they come with the limb swelling or mass. But as you see, the lytic lesions are longitudinal. It's parallel to the bone. It's like you are in the connected gaucheral bone, and we call it the onion skin. And thank you. Do you have any questions؟ هل عنده أي سؤال؟
الله يعطيك العافية دكتورة.
الله يعافيكم. راح أبعث لكم سلايدات، بس راح أضيف عليهم سلايدين ل most common emergency أو acute complication of pediatric malignancy leukemia and lymphoma.
خلاص إن شاء الله
Which we
بإذن
call
الله.
it the tumor lysis syndrome. Tumor lysis syndrome, it happens when you have a very high mass of the malignant cells and they start to lysis immediately, and you have all the intracellular components are extracellular, such as potassium, very high potassium, phosphate, calcium, severe electrolyte disturbances, high urea, and this is a medical emergency. It happens when you have a high volume of tumor cells, such as when you have very large hepatosplenomegaly, so you have a very high load of the malignant cells. And when you start, it happens usually when you start treatment, because you give chemotherapy or steroid to kill these cells, and so the intracellular components are coming out, and this need an urgent treatment with very high hydration, some special medication given to get rid of this intracellular component by the kidney, because it may cause acute renal failure, and the severe electrolyte disturbance such as hyperkalemia may cause arrhythmia and death. عشان هيك أي حدا عنده hepatosplenomegaly and for example you suspect leukemia, you don't give steroid at all. And أي حدا عنده lymphadenopathy hepatosplenomegaly, you suspect lymphoma, you don't give steroid. الستيرويد عادة عنا بالطوارئ بيعطوها للطير الطاير، لأي حدا بيشكي من أي شيء بيعطوا ستيرويد. الستيرويد هي as I said the treatment of leukemia first week is only steroid, and with the steroid the acute lysis syndrome, tumor lysis syndrome may occur because it's for us the steroid is part of the chemotherapy. عشان هيك أي حدا عنده hepatosplenomegaly، أي حدا عنده lymphadenopathy، أي حدا شاك بمالجنسي ما بتعطي ستيرويد لأنك راح تقتل. اوكي، راح اضيف عليها هدول السلايدين ان شاء الله وابعث لكم اياهم.
إن شاء الله على خير دكتورة.
امتحانكم الاحد الجاي ان شاء الله بالتوفيق.
بإذن الله.
اي ساعة؟
والله لسه ما حكوا لنا أي ساعة بالضبط.
على خير ان شاء الله.
إن شاء الله على خير.
خلاص نشوفكم
الله يعطيك العافية
بالامتحان ان
دكتورة.
شاء الله. Good
إن
luck.
شاء الله. شكرا دكتورة، يعطيك العافية.